A very good afternoon to everyone. And in conjunction with the World Ovarian Cancer Day, today we will be speaking to Dr. Tan Teck Sin, consultant obstetrician and gynecologist from Subang Jaya Medical Centre. Hi, doctor. Good
Hi,
afternoon.
good afternoon. Good afternoon to you, Vishala, and good
Yes.
afternoon to everybody.
How are you doing this afternoon, doctor?
Hi,
If you
fine, fine. Thank you, thank you.
your wards and went for your
Yeah. We're doing fine, doing fine.
Okay. So, doctor, today is World Ovarian Cancer Day, and as part of your profession, you've seen many patients, many ladies who have came in with a similar issue. So, I have come up with some questions for you, and I'm sure at the
Yeah,
end of the webinar, there will be more questions from the public. So, if
yeah.
any of you all have any questions, please wait to the end of the webinar. We have a 5 minutes Q&A session, and you can drop off your questions in the Q&A box, and we will get back to you later. Okay? So, doctor, I guess the first question I have to ask you, right? What are the early warning signs of ovarian cancer? Is there an early warning sign?
Hmm. You see, ovarian cancer is one of the diseases that's very difficult to diagnose.
Mm,
Um, to just your question said, is there an early warning sign? Most of the times, unfortunately, there is none.
mm,
It is a character of the disease that it presents in an early part of the disease is very quiet. It doesn't give you any symptoms, and it shares the unenviable position, a similarity with cancer of the pancreas. Both of these cancer of the pancreas and cancer of the ovary, they're very quiet most of the times until the advanced stages. And in
mm,
ovarian cancer, about 70%, I mean 7 in 10 patients that we see are already in the late stages. Only very occasionally do we catch them in the earlier stages. Maybe nowadays, because of the screening, people are a bit much more health conscious. We do get the odd ones that come quite early, but most of the times they're quite late. And that's no problem. There's no fault of anybody else. It's just because it's the character of the disease, it's how it presents.
So I guess when someone says they are bleeding for the entire month, would that is that a late stage or
Bleeding is not a common symptom of ovarian cancer.
okay, all right.
Bleeding, and the most common symptoms of ovarian cancer are very non-specific symptoms. Some
Ooh.
things like, they feel uncomfortable in the tummy, bloatedness, feel just, belching, sometimes, passing a lot of wind sometimes, and then, and only in very occasional cases where, because one of the things that happen in advanced ovarian cancer is water, a fluid, abnormal water accumulation in the abdomen. And when the accumulation becomes very much and very distended, sometimes they can present with difficulty in breathing because this water and distended abdomen splints their diaphragm. The diaphragm is our muscles that helps us to breathe, splints it and makes it difficult to breathe. But then not that's a very late presentation, mostly very non-specific. And
Mm,
it is very non-specific, and that is why, because it is non-specific, they go and see the GPs who treat them, with dyspepsia medicine, and then that delays it. Occasionally, they go to the general surgeons. The general surgeons are not familiar. They also, and all these contribute to the delay in diagnosis, and also, of course, if you have a delay in diagnosis, delay in treatment, and of course, outcome usually is slightly poorer. So it's a very difficult disease to diagnose.
okay.
Um, and there were sometimes very odd circumstances, I mean, I had a lady, just had a lady that had come with a nodule in the umbilicus. And of
Mm.
course, they think it is something, an infection, goes to the GP for a couple of months, goes to the surgeons, and then finally end up with me.
So it
So there's
really is, I guess, difficult to look for early signs. It could be pointing at different directions, and finally, only it comes to it could be
Yes,
this.
yes, yes. Unfortunately, that's the so-called the character. I mean, I
Mm.
can't put it better. That is how they present. Isn't it?
The
So, like
character
all
of
of
the
us have
disease.
our characters, our habits, and that's the character of ovarian cancer.
Okay. Really a complicated cancer, I would say.
It's not
So
complicated. It's complicated, yes, but its presentation is a bit unusual, a bit
unusual.
difficult. The
Okay.
other think that, of course, coming back to, if you look at all the female cancers, the female cancer of the cervix, female cancer of the womb, and female cancer ovary, unlike the cervix, which we doctors can see when we do an internal examination, you can see the cervix, and in the case of the womb, worst come to worst, we can do a biopsy because it is accessible from the outside. But the ovary is an internal organ and we have no access to it.
Correct. So, doctor, what are the key risk factors for developing ovarian cancer?
Of course, ovarian cancers, age is a common thing. We're talking, there are types and types of ovarian cancer. We're talking about the most general kinds. Mostly it is age related. They happen most commonly in the sixth decade, 50 odd years old, 60 odd years old, sometimes 40 odd years old. But there is a group of what we call juvenile ovarian cancers that are slightly of a different, but they're uncommon. And most of them, age is the most common thing, you see. The other thing I would stress is actually what we call nulliparity. The nulliparity means not having children. And of course, this is a very disturbing social pattern from the gynecological point of view, because most people have not have many children.
Yes.
And recently, and this Gen Z, I think Gen Z or Gen Y, they have this acronym called DINK, DINK, double income, no kids.
Yes.
which is all going against the grains of nature. You see, if you look in all our nature, the whole animal kingdom, including us, without being sexist or misogynistic about it, females are meant to have children. And when you don't have children, you're going against the grains of nature. If I can, I like to put up this slide. Can you put up one slide for me? This slide. Would you put up this slide for me? This one. This. Just hang on for a while. We'll just show you the slide. This is the slide. Which one? This one. Now, this one, can you put up? Okay. Now, if you all can see it.
No, it's not been shared yet.
Yeah. Share? Can you share it? Now, if you see this slide, I'm just the colored portion is the number of years that somebody has a menstruation. Now, take for example this lady that has no children by design, that they are not married or they are unable to get pregnant, whatever the reason is. Let's say on the average age, you get the first menstruation at about 12 plus or minus, and you stop your menstruation at 50 plus or minus. And therefore, this lady would have about 35 to 38 years of menstruation plus or minus. And that would seem normal to her because there's no pregnancy. Every month she gets a period. But let's compare it with this subsequent slide. This one, that's it. Now, if you look at the bottom one, the bottom part, if most ladies 50 to 100 years ago would have got married by social pressures and everything, by about the late teens, have a pregnancy which is marked in blue, a pregnancy 9 months, no periods at all.
Yeah.
Naturally, in those cases, they would have breastfeeding for another year or plus, which is marked in green, again, no periods.
Yeah.
Now, that's nature's birth spacing so that, they have no periods, no pregnancies, so that the child that is just being born can have enough nutrition from the mother, and the mother can have some time to recover. Now, very often they'll subsequently have another baby, some periods, maybe a miscarriage, and most people in maybe living a century ago would have 6 to 8 children. And that would be the same in Catholic Ireland now. In a lot of the Orthodox Muslim countries, they would have 6 to 8 children. And therefore, if you look at it, their number of years they have period would be about a third of them, about 10 years, 15 years kind of thing. And this is natural. And therefore, the womb have a period of rest. The ovaries have a period of rest, because when you have no ovaries, must ovulate, because then they will have a period. So period, and therefore now if you go back to the first situation again, just as a point of first situation, this is no, not this one. That's an abnormal situation,
Yep.
because you're like making your womb work overtime. You're making your ovaries work overtime than they're designed to, and that is why if you have no children, the chances of you getting ovarian cancer and womb cancers are significantly higher.
Oh, very interesting. Very interesting
Very,
take.
very interesting. Yeah.
Huh.
Now, you see, I in the 1980s, when I first became a trainee and started working medicine, and this was a slide put up by a female gynecologist. This is a slide this, this was a slide. This was a slide put up by a female gynecologist. The first slide of a lecture. I stress the word female because if any male were to put up that slide in the 1980s, he would be lynched and be accused of a sexist. But it basically sums up what I was trying to say. I remember this slide very clearly because it's very interesting. And she says a woman in 25 often should be barefoot in the kitchen. So basically, she says that childbearing is normal.
Mm. Mm.
And this was in the 1980s. Of course, now things have changed. People are
Correct.
more open now.
Correct. But it's a very interesting take about what you say, how pregnancy is a natural process. It gives the rest to the
Yes,
ovaries.
yes.
Interesting.
And it is no doubt about it that the current figures and data go back. I can
Okay.
go. The current figures and data shows that ovarian cancer is much more common in people um, with no children.
Okay.
Even in my own single-handed practice, a quarter or a third of my patients who have ovarian cancers have got no children. And I have spoken to my colleagues in Institute Cancer Negara, which of course they have got much more patients. And the head of the department also says they have about a third of them have no children. So that's a very important risk
Or
factor.
direct risk factors.
Uh,
So,
of
doctor,
course, there's another part. There's another part of this genetic factors also.
yes.
One of the most common, of course, like everything else, the cancers and the ovarian cancers, and there are very types of ovarian cancer, but the most common ovarian cancer, the epithelial ones, and one type of them has got inheritance, has a gene defect. They call the BRCA gene, the breast cancer gene.
The BRCA gene, yeah.
BRCA gene. And I'm sure all of you have heard of the very famous, what do you call it, Angelina Jolie,
Yes.
who had the BRCA gene. And she took a very bold step on removing her womb and breast because her family history is so strong. And then to prevent that, she removes her womb and breast even before they get cancerous.
Yeah, very interesting. So, doctor, speaking about Angelina Jolie, and sometimes ovarian cancer can be hereditary. So, should someone consider genetic testing?
Of course, ideally it is. You understand, but this is a personal variation. Each of us. Some people want to know about it. Some people don't want to know about it. Of course, that depends. But if you want to know it, facilities are available. I think that if we can get screening done, they're blood tests, but they're unfortunately very expensive. A word of caution there, because you see, when you do the genetic testing in this country, the insurance companies can have this thing and can make use of this information to deny you buying insurance if you are genetically positive for this BRCA gene.
Yeah.
So you may either want to buy your insurance first, then get the testing done. But you can never tell some of the insurance company, even though you declare upfront. After some years, they ask you to upgrade and review, and that's when they will deny you. So you have to check with the insurance company. So I'm not very sure about that. But that's something non-medical, but still relevant in real life.
Okay. So, doctor, I remember this now what you were saying, the way ovarian cancer presents, especially when science and all that, it's not very easy, it's not straightforward. What diagnostic methods are used to detect ovarian cancer? I mean, you say people start in the GP clinic and, after a few months, they end up in your clinic. Yeah.
Well, mainly not that. Actually, I think better thing will be what screening tools we have. We don't have very good screening tools. I mean, like cervical cancers, the pap smear is almost an ideal, together with some other tests, is an ideal screening tool. But in ovarian cancers, we don't have. We have been trying them in same method, but so far the best method is still having a vaginal ultrasound done from down below, combined with the blood test, a specific blood test called CA125. But
Okay.
they're not. The correlation is not perfect in the sense that you definitely where you're positive, you come up positive results there. And if you do all these tests, the one of the results that come out is there are a lot of so-called
Ambiguities.
false positive, which
False
means that we
positive.
think that the screening thinks that you have cancer, but you actually don't have, and it's only found out when you do the operation. So that's what we call false positive. The false positive is still significant. Unfortunately, there have been a lot of tests, a lot of research getting done, and a lot of trials, but so far none has been very reliable. And the gold standard, or rather the accepted gold standard, still today remains the transvaginal. That means getting an ultrasound through the vagina, and plus or minus the blood test.
Okay. Okay. I see.
Now, but once you diagnose it, of course, you can have. They say the diagnostic test. What are the diagnostic tests? Of course, you get what you need tissue biopsy if you can get it, or fluid that I told you just now. Sometimes on the fluid that we can take a little bit of fluid out and drain and look for cells, and of course the imaging, either the MRI scan or the CT scans.
Okay. Okay. Thank you, doctor. So, doctor, my next question is, how is ovarian cancer typically staged, and how does that affect treatment options?
Yeah, you see, staging is actually done by an international body, and ovarian cancers are usually staged under what we call the FIGO stagings. FIGO, the acronym is FIGO. It actually stands for the International Federation of Obstetricians and Gynecologists. And what happens is that this world body, every 3 years, they have a meeting.
Okay.
And they collect information from everywhere else and then pool the information and data. And then they do the staging. Now, when we do a staging, there is a purpose in staging. The purpose of staging is to find out, what is the likely outcome if somebody has stage 1 disease. What is the likely outcome, and therefore we can do the we can apply treatments that are deemed appropriate for that stage. You see, obviously we don't want to overtreat. We don't want to treat early disease. Everybody give chemotherapy.
Correct. Correct.
So we try and so far the purpose of staging is to guide us as what is the probability of the outcome of the disease, what will happen to the disease at that stage, you see? And then we treat them accordingly. And that's what we call the FIGO staging, and that's stage from 1 to 4. And it stands the logical stage 1 is early disease, stage 4 is very advanced disease. And even the 1 to 4, there are sub divisions A, B, and C, but we need not go through all this. But basically, it just gives you stratifications. Of course, 1A is better than 1C,
Correct.
3A is better than 3C, but the worst is 4B.
4B. Okay. That's nearly the end stage, I would say.
The end stage in 4B.
So, doctor, talking about how that identifying signs is not easy for ovarian cancer. In your experience, when you have seen women, normally at what stage have you seen them?
Of course, I see them from stage 1 to stage 4B.
Okay.
And more, and like I say, coming back to where 70% of them, 7 out of 10, will present in stage 3s and 4s.
Okay.
1s and 2s are not that common, about usually about 20 to 30%.
And what's the survival rate like, especially when they come stage?
Or if you're talking about, I will say, if you stage 1A, which means that it is confined, and it is confined to the ovary, no spread, doesn't even go to the surface of the ovary, it's not too bad. You can get about 90%, but it drops gradually down to when you're 4B, you're about 30%. When you talk survival rate, that means we have about, say, for example, 100 of the same stage, and we treat them at the end of 5 years, how many are cured? Or are well enough, not cured. It may not be cured. That means they are still alive, basically.
Still alive,
because
yeah.
4B,
Surviving the disease, yeah.
you may be every 5 years alive, but you may still have the disease.
Okay, okay. So, doctor, what are the current standard treatment options for ovarian cancer?
Like most cancers, most ovarian cancer, stage 1 to 4, the first symptom, the first treatment is surgery. The upfront thing is still surgery. Now, there in very rare instances, I won't say rare, uncommon, when the advanced stages is so advanced that surgery is not the first thing. We may give chemotherapy to shrink the disease first, and then come back and do surgery. That's what we call neoadjuvant chemotherapy.
Mm,
But most of them, surgery is the most common thing, and you will need to do the surgery. And the purpose of the surgery, the objective is to remove as much ovarian tissue, ovarian cancer, as much as you can see. But that's not always possible, especially in stage 3 and 4. Uh,
Is it
quite
because it's already spread and
Yes, you see, unlike it spreads in it's a lot of places all over the place, so you can't really take out everything really. So what we call optimal surgical removal is not always achieved, but that would be the aim.
Okay, okay. So, doctor, earlier you shared about pregnancy is a natural process. It gives the ovaries the rest that it needs. But ovarian cancer can happen at any age. So, how does it affect fertility if someone has ovarian cancer and I'm planning to have kids later on?
You remember that you tell me what was the one of the things that you asked me, Vishala, was what is the what are the causes, or rather the factors, that risk factors of ovarian cancer?
Hmm.
Age is one of them. Luckily, most of them, as I told you, are in the fifth and sixth decades of life, and at that time, uh, fertility is not so much an issue.
Yeah.
Yeah, but as I said before, there are some that are young.
Yes.
Then some are young, and then there's different kinds of ovarian cancer affects usually the young. Now, in these cases, of course, it is the ovary. The ovary produces eggs. The ovary produces hormones. And of course, when you have ovarian cancer, we may have to remove the ovaries. And therefore, it obviously stands to reason that the fertility will be affected.
Yeah. 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 Okay.
So in this kind of instances, many years ago, we have actually no option, But of course, nowadays, with what we call IVF and all these artificial things, there are something. You can freeze of course, if both the ovaries are already affected, there's no choice. But
Yes.
sometimes it
Yes.
affects one ovary, the other ovary is healthy. We may want to what we call preserve the ovary, because the treatment, sometimes chemotherapy can also affect the healthy ovaries, and may
Yes.
affect this fertility. So we may want to so-called preserve the ovarian function. Uh, and in those cases, you can do what we call egg preservation. That means collect the eggs out and freeze them. Egg cryopreservation, and freeze
Okay.
them. Unfortunately, egg cryopreservation can be done, but the results are, you see, when you freeze the eggs, when you want to use them, you have to thaw them.
Yeah.
And the thawing survival rate of ovaries, of what we call eggs, are not that good. Uh, the other way is that nowadays they also can take strips of what we call tissue, take strips of normal tissue and freeze them outside. That might be a better thing. Now, these two options are not readily available. Only very big centers that do this kind of what we call artificial IVF work have them, but not universally available.
Okay, okay. So, doctor, we have spoken great length about the disease and how it's not easily detected. Not to say easily detected. For you, the signs are not easily detected, and
Mm.
we've talked about the treatment options. So, I'm sure everyone is waiting to ask this question as well. What lifestyle changes can help improve outcomes or quality of life of patients?
I I keep telling go and have a normal family life. Having
That's
And
good.
of course, like everything, I think important is to have children.
Mm.
Which is normal. That's very protective. Um, Unfortunately, it doesn't go down well with a lot of the young people.
Young people, yeah, I know things have changed today.
Yeah,
Not,
yeah, yeah,
yeah, yeah, yeah.
yeah. Lifestyle, of course, like every general lifestyle, we don't have special things that like But I think having a family, having children is the most important thing that I would advise.
Very nice. Thanks, doctor. So, doctor, why is it important to do cancer research in the Asian setting when it comes to ovarian cancer?
Every disease, there are differences in all of us. There are, of course, we're all human beings, but there are regional, epidemiological, and geographical factors. Some diseases are common in people with dark skin, like sickle cell anemia is not found in other things, and we all have regional variations. You see. And it is, of course, important to know what our local population, there may be differences in our pattern, and it may not be related to our lifestyle, but there may be some pattern. And therefore, it is important. And see, even treatment responses are different. Sometimes different people are from different populations. The Caucasians may behave slightly differently. The Asians may observe differently. And even within, say, for example, like this doesn't happen in ovarian cancer, but in certain diseases, say, for example, they are much more common in the Chinese population and some more in the Malay population. Some you understand. So therefore, it is important to do local data, and there are some differences. And then I think this cancer research mission have done some local data on breast cancers.
Yes.
I think they have, but they haven't done on ovarian cancers because ovarian cancers are not that common as breast cancer.
Okay. So, I mean, for ovarian cancer, of course, the genetic counseling team does a lot of research in it and all that as well. Yeah.
Sure.
So, doctor, last but not least, how can people advocate for more research and awareness for ovarian cancer?
Awareness. Of course, hopefully with all this research, we get some more data, and that will help us in treatment and prevention. Prevention is important if you can. And until we have that, if you don't do the research, you'll never know it. So you have to start doing some research.
Correct.
And therefore, that's something that you may not yield anything in the end, but without doing that, you don't know whether you yield any result or any so-called things, recommendations. So therefore, it is important to know. It's difficult in this country because we don't have a centralized medical records. And a lot of times, even among doctors, I must say, not everybody will report and keep records of their cases. Not everybody does this.
Correct.
And unless you are working in an academic institution like the universities and maybe large hospitals like this, there may be some centralized records. But if you are standalone, nobody knows what you're doing.
Yeah. Correct. Yes. So, doctor, I know I told you this is your last question, but I have one more question, doctor. For those
Sure, carry on.
For those who are listening today, what will be your advice, when it comes to early testing, or, if they are experiencing some symptoms and they're not sure what it is, what will be your best advice to them?
First of all, if you have a family history, I think you should definitely, let's say if you have first degree relatives, meaning mothers, sisters, or second degree cousins, first cousins that has got breast cancer, because they're breast cancer, ovarian cancers, you should go and see your doctor yearly and some form of screening. And of course, that's what I would do if you have risk factors.
Okay. All right. Thank you, doctor. We have already come to the end of my question and answer session with you. So I'll be presenting a bit about Cancer Research Malaysia's effort.
Sure.
Dr. Tan was saying earlier, how cancer research is important, and it presents differently in different populations. So in the Asian settings, certain cancers can be presented very differently, and that's why it's important to do cancer research. So how can you continue to support us? Let's share my slide. Okay, so we have, you can share information about us. You can like our Instagram page, like our Facebook page, share with your friends and family, share it with your company, so that they can continue to support us. And if you're thinking how else you can join individually and support us, we have the Race Against Cancer run that's happening on the 25th of May, and all proceeds from this from this particular race will go towards Cancer Research Malaysia so that we can do more impactful research on Asian cancers. Okay, so thank you, Dr. Tan. We have come to the end of our webinar. And to everyone who's listening here today, thank you for your time. Thank you for your time, Dr. Tan. Thank you, SGMC, for your support and collaborating with us. Thank you, Dr. Tan.
Right. Thank you. Thank you.
Thank you.
Good. Okay, right. Bye-bye, Ishala.
Bye-bye.
Thank you.